So, always we end with the dessert. So, our dessert today, aortic stenosis, transplant challenges, and prosthetic innovations. Chairperson, Dr. Fadi Gergis, we have to congratulate him because also he got consultant cardiologist this year. And Dr. Tamer Assam, or Tamer Badawi, as he's written in his Mediclinic profile, we already congratulate him. So I will welcome them to come to the stage and present the two last speakers. And as we said, the last is always the dessert.
Good evening, everyone. So last session is very interesting. It's about management of severe aortic stenosis in renal transplant patient and as well as the patient prosthesis mismatch. And two of our eminent speakers, Dr. Mohammed Andron, Dr. Walid Shaker. Dr. Mohammed Andron is a consultant intervention cardiologist, HOD of the Mediclinic Airport Cath Lab. The floor is all yours, Dr. Andron.
Thank you, Dr. Fadi. Thank you, Dr. Tamer. And the presentation, I'm going to present a case about severe aortic stenosis in patients with renal transplant. So this is a case presentation. The background, aortic stenosis is actually the most common valvular pathology in end-stage renal failure. Severe aortic valve calcification almost universal in this group of patients. And this CKD stage more than 3 is important predictor of outcome and worse mortality, acute renal failure, and stroke. We know that already. So the outcome of TAVI, which is transcatheter aortic valve replacement versus surgical aortic valve replacement in patients with end-stage renal failure or recipient of kidney transplant is not well known. The potential challenges of the treatment of severe aortic stenosis in kidney patients, in renal patients, whether they have end-stage on dialysis or they have kidney transplant, the number of things. Mainly the heavy calcification of the valve, which can affect the outcome of transcatheter valve replacement. They have higher risk of stroke, more than 3%. And 30 days mortality of 5%. Acute kidney injury, which is almost 10%. The potential blood loss and blood transfusion, especially in patients with the kidney transplant, so that can affect the longevity of the kidney. Kidney allograft failure, and the use of vasoconstrictions during the procedure, which is commonly used during the transcatheter and perhaps the surgical also aortic valve replacement. So that all can affect the perfusion of the kidney, of the transplant kidney, and can lead into kidney failure. So our case is a 79 years old diabetic patient, renal transplant 8 years ago, and she is actually a private patient from Sudan. She presented with severe breathlessness ongoing for a few months, and her echocardiography showed severely calcified aortic stenosis with good left ventricular function. The peak gradient actually was 190, and the mean 130, which I have not seen before. It's unbelievable. She has severe concentric LVH. So I would show you her echo in a minute. So because of the protocol is to do, we do CT of the aorta, planning before the aortic valve replacement, especially with the percutaneous treatment. So that's her valve, and you can see the valve is tricuspid, so 1, 2, 3 deflates, heavily calcified. This is the sinus level. So not big sinuses as well that affect the transcatheter treatment, but heavy calcification. You see those white spots. And this is the annulus. So you go down, you scroll down, you go to the annulus. Annulus, again, is not big, and you can see there already calcification in the annulus. And that's bad sign in terms of treatment, of percutaneous treatment, because when you inflate the balloon, you can cause rupture of the annulus. And we measure also the height of the coronary of the coronaries, height from the annulus. So this is 13.9 millimeter, which is generous height, so acceptable. Anything below 10 is considered high risk for coronary obstruction. And that's her echo. You can see, so she has severe LVH. And that's because of aortic stenosis and also maybe kidney, the renal patients. And that's her 4-chamber views. You can see the calcification everywhere, and the mitral also, mitral annulus calcification. And that's her aortic valve. She has mild aortic regurgitation. And that's the gradient. So you can see the gradient is unbelievably like 131, 191. And that's aortic stenosis, not because of the LVOT. You can see the envelope is in keeping with with the true aortic stenosis. So, this case, what are the challenges in this case? So the challenges would be the likelihood of severe hypotension during the crossing of the valve, even with the wire, because don't forget the area here, the aortic valve area is probably less than 0.4. So even the wire is going to cause most likely severe obstruction of the flow and severe hypotension. That's, you have to put this in your plan. The fluid and inotropic resuscitation, so that can affect the kidney, especially vasoconstriction. The balloon pre-dilatation, which is mandatory in this case because she has severe calcification. And the complication of the balloon, which can cause a stroke, high risk of stroke. Severe hypotension during the valve deployment, you have to be taken into consideration. And avoidance of contrast, because you don't want to cause, again, kidney injury with the combination of hypotension and contrast. That's effectively going to kill the kidney. And accepting suboptimal results. So you have to have a plan that the suboptimal results probably okay here. So this is the case. So we go usually transfemoral, a big sheath, and we go the big tail into the aortic root. So this is a non-coronary cusp with the big tail in the non-coronary cusp. You can see already the amount of calcification in the aorta. And we insert temporary pacing wire, and this is to pace at high rate during the balloon inflation, so the balloon doesn't move. And then you cross the valve with wire, special wire. This is special wire which has a curve, so it doesn't cause perforation. And this is the valve which we inserted here, which is this is a Navitor special valve, which has this is a 19-hole valve, self-expandable valve. So here we cross the valve. So the patient at this stage had actually severe hypotension. We had to give her inotropes. Blood pressure, I think I remember, was unrecordable, to be honest. And we started resuscitating her during the valve deployment. We almost lost her, but you'd imagine with the severely calcified aortic valve, and her age is almost 80. This is the valve deployment, so it's a self-expandable valve. So you remove the sheath and you gradually deploy the valve, but you have to take different views so you make sure the valve doesn't pop up or pop down into the ventricle or to the aorta, especially with heavy calcification. And you can see already the indentation, maybe it's not well projected on the valve. So the valve here doesn't open well because of the calcium. So sometimes you have to resheath again, and that you have to take the pain of hypotension and so on. So again here, this is, so the valve now is opening better. You can see more symmetrical opening of the valve. And so just taking different views, make sure the height is good. So like this is technical issues. Again, so now the valve is fully deployed. We didn't inject contrast here. Usually we will do contrast injection to make sure the valve, there is no leak around the valve. But here, because of the kidney, we didn't want to inject contrast. But you can see the valve is reasonably opening nicely. There's no indentation on the in the cells or in the stent platform. And we watch for a little bit just to make sure that there's no the valve doesn't move up or down. Usually, it's well held, protected by the calcium. So the calcium keeps the valve in place. And again here, so that's almost, we finished the procedure. So after the procedure, the echo showed significant reduction in the aortic gradient. Was not normal, so normally we would aim for a gradient of less than 10, but in this case we accepted the gradient of, I think, around 15 to 20 millimeter mercury. Don't forget her gradient was 130, the mean gradient. There was no aortic regurgitation, that's very important, and there was no need for a permanent pacemaker, which is almost 10% of the patients undergoing transcatheter aortic valve replacement require a permanent pacemaker. The renal function actually did not did improve maybe by the fluid. So her renal function remained stable, and I think got a little better maybe because of after the valve replacement, the perfusion of the kidney improved. At 6 months remote follow-up, she's doing really great and no complications. Thank you.
Thank you very much, Dr. Andron. Just a quick question. Do you consider this high-risk procedures, because that basically was not even a severe aortic stenosis, it's a super severe, or we call it critical aortic stenosis.
Critical, yeah.
Do you consider getting the use of some kind of a mechanical support device, like a short-term one, like the Impella or the intra-aortic balloon device during the procedure?
It's a good question, actually. I think there is one study on the use of aortic balloon pump during such cases. Now, Impella would be very difficult to go inside with the severe aortic stenosis, so it's a big sheath. But the use of intra-aortic balloon pump, there are some data on it, but it's not recommended for routine use, even in high-risk cases. And it's going to make your procedure more difficult because you have to have 2 accesses. We already have 2 accesses, but it's going to have more complications from the second access. So usually we don't actually use it routine, and it's used very, very rarely.
Very good. Thank you very much. Any questions from the...
One question for Dr. Muhammad. How do you choose the size of the valve? And what is accepted gradient after the tablet?
The size of the valve, you have each company depends on the type of the valve, because there are like few in the market. So they have their own chart. Usually you do CT scan. So CT scan, the CT as we showed in the first few slides. So they will take the annular measurement, the coronary height, and so on, and then they have a certain parameters to use. Depends on number of factors taken into consideration, but it's clear guidance on which valve size you use. In this case, I think we used a 26 millimeter valve.
So it's mainly the CT measurement.
CT
doesn't have to do with the BMI of the patient.
Yeah, no. CT measurements all depend on it. And CT is mandatory. Before, in old days, they used to use transvisual echo, but that turned to be actually misleading in terms of either you oversize or undersize. But now the CT is being used universally to measure the valve. And the second question about the
accepted gradient on the...
Yeah, the gradient, anything single-digit gradient is the standard. So you should leave the lab with a single-digit gradient. That's the mean gradient. So mean gradient should be below 10 or below millimeter of mercury by echo, and should be actually below 5 millimeter mercury by invasive measurements. That's the standard acceptable. In this case, actually, we accepted a gradient of around, I think, 18 to 20, because don't forget she has, so you always have to take her age into consideration. What's her life expectancy? She's 80 with a kidney transplant, so she will not live more than 5 to 7 years. And she has severe calcification in the annulus. So if you do post-dilatation, you're most likely going to cause rupture of the annulus, and that lead to death. Almost 100% risk of death. So you have to balance the risk and the benefits.
Dr. Price, please.
Yeah, Dr. Price, okay.
Do you think that the immunosuppressive medications they are using for kidney transplantation can have a negative effect on your TAVI as a bioprosthesis?
It's difficult to know. There's absolutely no randomized data. It's only case presentations, and on this is no, we don't know. But it's likely, I mean, you will increase your risk of course, calcification, vascular access complication, dissection. Yes, I would imagine so, especially the cortisone and the immunosuppressants. but we don't have any data. And it's, as I said, whether surgery or transcatheter replacement, which one is better? Again, we don't know. Again, I think with surgery, risk of damage to the recipient kidney is not small.
This new valve, Percevial, it's called, with mini surgery, sutureless valve they are using today instead of TAVI in some
The
patients.
sapien valve.
Sutureless,
You mean for open surgery?
yeah, small.
Yeah, but again, you have to have small incision. In her case, risk of complications, infection risk post, even if you do mini sternotomy, still the risk of infection is not small. I mean, she's on immunosuppressants, cortisone, she's 80. I think her surgical risk would be high. I think in this case, I think transcatheter aortic valve replacement would be the best option for her, as long as she gets safe out of the. I remember this case we thought we lost her because her blood pressure was unrecordable for at least 2-3 minutes. No blood pressure at all. And the resuscitation started CPR with a chest compression during the implantation of the TAVI, interrupted for short during the implantation. But once we deploy the valve, blood pressure picked up. And you have to have a good anesthetist with you because they have to give inotropes definitely when the blood pressure drops. So they have to be switched on.
I agree. There is a high frailty score for this patient, and if you calculate the Euro 2 score and the STS score, it will be very high. So it goes in favor of TAVI.
Yeah, definitely.
Yeah. Thank you very much. Any further questions, Dr. Shaker? Dr. Walid?
For a minimally invasive surgery or even with a self-deployed valve or sutureless valve, still we need to go on heart-lung machine, which would be more harmful to the kidneys. But I think this patient was really indicated for a TAVR, and I think this is according to the guidelines, and we should not give her any surgical risk.
Thank you. That's good to hear from the surgeon. Yeah. No, I think that's fact, definitely. Yeah. As long as you get her safe out of the cath lab, at least. Yeah, it was a tough case. Yeah. Okay, thank you.
Okay, let's move to the next topic. Thank you, Dr. Andrew. Yeah, please go ahead. 2 more questions, okay.
So with one quick question, that's a fantastic talk, and I think you're very brave to take on cases like that. That's superb outcome. What's your minimum caliber for the femoral arteries, and what about the tortuosity? Yeah,
that's a very good question. I think, don't forget, she has kidney transplant also on the right side, to my memory. So we avoided that side because there is a potential harm to the kidney, to the transplant kidney, because they implant the kidney, I think, in the pelvis. So sometimes you can go with the and this is a big sheath, like 18 French sheath. You have to have minimum diameter of 5 millimeter in the femoral artery. So minimum diameter 5 millimeter, and with little calcification. If you have too much calcification, the diameter should be 6 millimeter. And again, so by pushing the sheath and the wires and so on, you could have emboli into the artery feeding the transplant kidney. So that potential ischemia to the recipient kidney. So we went from the other side with the big sheath, but her femoral arteries were acceptable size for that. I mean, at the moment now the registry is 95% of the cases are done through the femoral arteries worldwide. So even if the femoral artery is like 5 millimeter, now we can use the smaller type of the devices of the TAVI, because we have number of them in the market. Some of them have a smaller profile than others, just to accommodate the femoral, because the vascular complications actually are the most common complications. The vascular complications almost 10%, including the rupture of the femoral artery, perforation of the iliac artery, pseudoaneurysm, you name it. They have so the femoral access is very important, and the size should be minimum 5 millimeter, ideally 6 to 7 millimeter, to accommodate the big sheath.
Thank you, Dr. Andron, for the wonderful talk. Thank you very much.
Thank you. Thank you.
So So we welcome our next speaker, Dr. Walid Shaker. So Dr. Walid is my dear friend. He's a consultant cardiac surgeon, and he's the head of the cardiothoracic service in Mediclinic Airport Road. The floor is yours, Dr. Walid. He's going to guide us through patient prosthesis mismatch.
Thank you, everybody. It's really very difficult to talk after Dr. Andron, such a skilled interventional cardiologist. Today I will speak about a very old topic, but in fact it is old but popping up to the surface nowadays with the TAVR, which is a patient prosthesis mismatch. So we know that the PPM occur in maybe 2 to 20% of patients, and it has a very serious effect on the risk of mortality and the heart failure and the risk of rehospitalization. It leads to less regression of left ventricular hypertrophy, higher incidence of cardiac event, and decreased long-term survival. We have to anticipate the risk of PPM, and this should be done by proper planning of the surgery and during the surgical techniques also. We have many ways to prevent the PPM by implanting newer generation of prostheses, or by enlarging the aortic root annulus, or by shifting the patient to TAVR, which give the patient better pressure gradient across the prosthesis. So we know about the PPM that PPM definition comes like less with an. Thank you. So the PPM, we know that the definition comes like an EOA index of less than 0.85, and the effect of mild and moderate PPM is not very significant, but the effect of severe PPM is really significant on the patient outcome. The severe PPM come when the IAOA is less than 0.65. We have recent definition of the PPM also related to the patient BMI. So we found that the threshold of IAOA is less when the patient is more obese or the BMI is more than 30. So it can come down to severe PPM when the IAOA less than 0.55. We found also that there is a big difference, which is a major problem happened, major difference between the reference AOA in the prosthesis brochure and the measured AOA post-operative. As we see here, we can know about the effect of the index effective orifice area on the pressure gradient across the prosthesis, and we know that the less the IAOA, the more the pressure gradient we are facing across these prosthesis. This also graph shows the effect on the pressure gradient and the effect on the cardiac output and the cardiac index along the years. And as we see, the less the indexed effective orifice area, the more the gradient, and the less is the cardiac index and the cardiac output. We have good news that over time, the EOA gets better, gets bigger, and the gradient gets lower. And we have an explanation for this because of the industrialization of our Teflon pledget and our ring of the prosthesis, which give better EOA over years and over time, and which lead to better pressure gradient with time. So we know that even if we measure a little bit high mean pressure gradient, we know that this will improve with time. We know also by many studies that the IAOA is different between surgeons. It depends on the surgical technique and the performance, how we do the debridement of the valve, and how we measure the effective orifice area and the choice of the prosthesis. This is how we need to plan our surgery. As Dr. Andron said, we have to measure the annulus in an accurate way. We were doing before the transesophageal echo, the 3D gives us a lot of information, and then we shifted to the CT scan, and then the intraoperative measurement, of course, is of great value. Second, we have to choose a prosthesis, and we have, of course, the choice between the bioprosthesis and the mechanical prosthesis. We have many prostheses in the market with different reference EOA and with different performance. We have to choose the right prosthesis for the right patient. After choosing the prosthesis and the annulus of the patient, we have to decide about the EOA, the indexed EOA of the patient, by calculating the body surface area, better also to get the BMI of the patient. And we know that the severe ppm, as we said, is less than 0.65. And we know that the moderate or mild ppm is between 0.65 and 0.85. So this is a way we need to plan for every surgery before going to the operation room. This table shows how we know about the EOA of the different prostheses available in the market. And as you see, for example, I will show you one of the most common here. We have the Magna Ease, for example, the Carpentier Edward. If you see size 23, in fact, the AOA is only 1.8 or 1.9. So size 23 doesn't give you an effective orifice area of 23. It gives less. Another important mechanical valve in the market, the Onyx, for example, at size 23 can give you 2 or 2.1 effective orifice area. This should be put in mind during your choice of the valve. And in fact, we know by experience that even these values are higher than the measured EOA. So when we measure this EOA after the surgery, we have less value than this. Of course, we have to target, as Dr. Andron said, the lower pressure gradient we can, but in the surgical, in SAVR, we can expect a mean pressure gradient less than 20. This is acceptable in the surgical aortic valve replacement. These are two patients. This is the first patient we operated recently in Mediclinic in cooperation with the heart team. So the first patient is a 62-year-old, and he has an end-stage aortic stenosis, very high gradient, very calcific valve. His body surface area was 2, BMI of 30, and his measured aortic annulus was 1.9. We choose for this patient a Magna Ease valve 23 size, and the reference EOA for this valve was 1.9. We have to calculate the indexed AOA, and it was 0.95, so away from any ppm. As we see the result here, so this is a preoperative gradient, and this patient had very high pulmonary artery pressure due to the left side affection, and this was a post-operative pulmonary pressure with a very good improvement post-surgical. The second patient was a little bit more complex because of his high body surface area. He's a 57-year-old male. His body surface area was 2.5, but he's an obese patient, morbid obesity with a BMI of 41. His measured aortic annulus was 2.2, and we choose for this valve during the surgical planning an Onyx 23, and we choose the Onyx 23 because it has a higher reference EOA, so it was 2.1, and his predicted IOA was 0.84. This is quite acceptable for this patient because of his BMI. His ppm threshold will be 0.65. So at 0.84, we were sure that this patient will not get a ppm. And this is a result of the patient before and after the surgery, with a major reduction in his mean pressure gradient. About this discrepancy between the reference EOA and the measured EOA, a task force was formed maybe in 21, including the surgeon in STS and AATS, including engineers, and to study in vitro about the real size of the effective orifice of different prostheses, and to put some guidelines and the standardization of this kind of prosthesis. And this definition came for the prosthesis. For example, we have the external sewing ring diameter, which is the outside diameter of the prosthesis. We have external housing diameter, which is the diameter of the metal of the prosthesis, and actually this is the size of the prosthesis. So when we have a size 23, it is the size of the metal case, and we have to also make sure that the ring, sewing ring, will accommodate in the valve. And then we have the minimum internal diameter, which is a real effective orifice area of the prosthesis. The same applies for the bioprosthesis by the same way, and this definition aiming at standardization of the size of the effective orifice area. Then we started to have a probability table. In this probability table, just to make it easier for the audience, I will just apply the two patients we discussed right now. So for example, with the first patient, this is the valve size from 19 to 29, and this is the body surface area of the patient, and this is the probability of ppm. So for example, the first patient had a 2 body surface area, and his BMI was less than 30, and we used a 23 size valve. We used also the best valve with effective orifice area, so this patient will have less probability of developing ppm. The second patient, for example, he has a 2.5 body surface area, and his BMI was more than 30, and the probability also was less. It didn't fall into the yellow part, which is more probable for the ppm. So the importance, of course, of this calculation and this standardization comes also with the recent trend of the valve-in-valve after the bioprosthetic, and we have to put in mind when we put a bioprosthesis for our patient to think about 10 or 15 years, this patient may need a valve-in-valve by TAVR. So the same apply, and the definition of the minimum internal diameter of the prosthesis, or the true ID of the prosthesis, is very important, I think, for the interventional cardiologist to plan their valve-in-valve. So the planning for the aortic valve replacement is not only a surgical act, it is a pre-surgical act or pre-operative, and then an intraoperative act, because again we are measuring the annulus of the aorta intraoperative after putting the suture and putting the Teflon to make sure that this annulus can accommodate the biggest valve. We need to make sure by this probability graphs and probability tables that our patient fall into the no ppm phase, and we should avoid the ppm cutoff. Our ways to put the largest valve, we have many ways. I think the most important way is by doing the proper debridement of our annulus and remove all the calcium, try to excise most of the valve leaflet to try to insert the biggest possible valve. We have another way is to put the supraannular. This is what I'm using always. This is the annular position of the valve. This is the supraannular, and this gives you maybe one size bigger than the annular size. We have also the technique, if we fail by debridement and the supraannular position to put or insert the proper size of the valve, we have to go for the aortic annulus enlargement surgery. And these are the two standard surgery. We have the next technique and the Manugian technique. In the next technique, we are cutting in the non-coronary leaflet to the nadir and cutting the annulus and inserting a patch, and this patch can give us increase in the size of the annulus. Yes, I'm about. And in the Manugian technique, we cut through the left coronary or between the left coronary and the non-coronary leaflet, and we go to the anterior leaflet of the mitral valve and we insert a patch, and this will give the same enlargement. Recently in 21 we have a new technique of aortic annulus enlargement, which is a young technique in 21. Still we have to wait for the studies about the result and about the complication. So we go in a Y incision below both left coronary and non-coronary leaflet, and then we insert a quadrangular patch, and this may increase the annulus size maybe 3 or 4 times the actual annular size. And with this technique, we can really insert bioprosthetic valve size 25 or 27, which is suitable to the valve implantation in the near future. So the take-home message, we have to plan for our surgery for aortic valve replacement. The patient imaging is very important, including the transesophageal echo, including the CT scan. We have to measure accurately the body surface area, the BMI. We have to know the patient activity, which is a very important factor. We have to know our predicted IOI, and choose the right prosthesis is very important with the right reference and the proper surgical valve debridement to accommodate the largest size, and if requires aortic annulus enlargement. Thank you very much.
Thank you, Dr. Walid, for this excellent presentation. Do you have any questions? Dr. Muhammad?
Thank you, Dr. Walid. Very nice presentation. And actually, it's very useful. So in terms of the PPM or patient prosthesis mismatch, so do you actually do this routinely for every patient, or only when you think the annulus is small and you have to choose like a smaller size valve, which is smaller size is 19 and 21 for you in the surgery?
Yes. In fact, it became a habit now. So for every aortic valve replacement patient, we are doing the same homework. So we have to calculate the body surface area, the BMI. We need to know about the patient activity and his physical needs. And we have to measure, as you said, the annulus in a very accurate way, because this planning will avoid many problems during the surgery. So we don't want to face any surprise. You should know about the valve, the type of valve you are using. You have to make sure that your valve will have a suitable effective orifice area for this specific patient. So it became like a homework, yes, for every patient, I would say. For this valve size, 19 and 21, we are not using anymore. Frankly speaking, and most of the surgeons are not using anymore. We prefer to insert 23 plus, especially for bioprosthetic valve, because this will give you a chance after many years to do a valve in valve.
So if your measurements from the annulus, and then 19 or 21, you would do a root enlargement routinely?
Yes. If we have to put a valve below 23, I would go for an annular
Because
enlargement.
in some meetings, the discussion would be, if you're going to put small valve and you cannot, and the risk of root enlargement, which to my knowledge, not all surgeons familiar with it, and is only like 10 to 15% worldwide. So they tend to favor TAVI with supraannular valve. Is that reasonable from surgeon?
Of course, that's why it's an open discussion in our team. I mean, if the surgeon is not familiar with an aortic annulus enlargement, the TAVR will be an option for this patient, because for sure the TAVR will give the patient bigger size of aortic valve. This is of no doubt, and this is one of the solutions. So we have many solutions. First of all, the debridement of the calcific valve, because we have to remove all the valve leaflet, and this will give a better size. And then we have the aortic annulus enlargement, and then we have the TAVR option also. So all these three options are valid to give this patient the best size to avoid any kind of PPM in the near future.
Thank you.
Sure.
Any more questions?
For aortic stenosis in past, the question was either tissue valve or mechanical valve. But recently, another question was very common for patients of aortic stenosis, TAVR or SAVR. Apart from age, physical fitness, comorbidities, there is in other factors which affect the choice between TAVR and SAVR.
I think we have clear guidelines, and then we have to tailor the choice according to the patient. I mean, every aortic valve replacement patient should be discussed in our team, and then to find really what is a suitable option for this specific patient. We have some guidelines and rules about the TAVR, and we have also our guidelines for the SAVR. And I think it's a matter of discussion for each patient. We know that, of course, a patient for high risk for surgery will be more suitable for the TAVR for sure. What do you think, Dr. Andron?
I think the age, the American guidelines, they use 65 years old as a age cut for the TAVR, which is, I think, is too young. The European 75 years of age. But I think 65 is probably too young. If you put TAVR now, and then the patient live like 20 years, so they have TAVI, and then maybe another one. So maybe I think in those patients better to have surgery, and then if the degeneration of the valve, they can have TAVI in the bioprosthesis by the surgical, inside the surgical, which would make more sense, I think, in my view. Unless if you want to use mechanical valve. If you use mechanical valve, longevity, of course, is much more. But I guess above 65, you routinely use bioprosthesis, correct? Or yes. So routinely, say above 65, bioprosthesis. You don't use mechanical valve.
Yeah, for the choice of mechanical, maybe I'll answer Dr. Ibrahim also first question between the mechanical and bioprosthetic valve. So we have, of course, guidelines, age guidelines. Up to 55, we have to use a mechanical valve because this will give the patient long term, and it doesn't need to change the valve after 10 to 15 years. Between 55 and 65, it is a gray zone. You can tailor the choice of the valve according to the patient. And after 65, of course, we prefer the bioprosthetic valve. So when we prefer the bioprosthetic valve, we have to check how is the surgical risk of this patient. And if the patient is frail enough and have high risk, so we prefer to do the TAVR. But if the patient is fit, we can still do the SAVR for him.
I think it is individualized for each case. So each case has its own favors regarding going for TAVR or for SAVR. It's, as you said, Dr. Walid, it's a hard team discussion and putting into so many things. Either the patient can be on warfarin or not, if the patient have high risk for bleeding or not. So many other things. So in total, in general, you cannot put rules unless it is, especially this kind of patient above the age of 65, they have other comorbidities. So it is a discussion and with the patient and giving him the option also. And I totally agree with you. Very nice presentation, Dr. Walid. Very nice.
Thank you. I fully agree. Thank you.